Oh, good evening.
Hello, David. How are you?
Good. How are you doing?
I'm fine. I think it's about time, right?
Yeah, it's about time. Let's start. Others will join as we proceed.
Yeah. Hope you can hear me well.
Yeah, yeah.
Yeah. Um, good evening once again, everyone. I missed this thing like just one week. The other week, I think. Okay, 2 weeks. The other week, I was listening to. I think that was Fabian. Pretty amazing. So, David, today we have two very simple case, not so difficult. I think it's about a 62-year-old female presented to the clinic with pain of the left hand for 3 months.
No, Joseph, can you work on your internet? I'm not sure if it's mine or not, but your voice is breaking and your screen has disappeared too.
Oh,
Hello, Joseph.
hello, can you hear me?
Can you? I'm not sure if it's just me. I'm not sure if it's my internet, but I can't hear you.
How about others? Can you see my screen?
Hello, Joseph.
Hello, hello.
Yeah, let's wait for Joseph to fix his internet. I hope he will be back soon.
Hello, David.
Yes, Joseph.
Can you hear me now?
Yeah, yeah, I can hear you.
And you can see my slides.
Yes.
Yeah. So this was a 62-year-old female who had pain of the left hand for 3 months.
Okay. This is left hand pain, so hand pain. I think so. Right off the bat, I'm not sure if I have a very good schema for approaching hand pain. But we are dealing with a 62 years old female who is presenting with left hand pain for 3 months. So whatever we are dealing with is appears to be something chronic. And Joseph, your slide has disappeared.
Yeah, it will come back.
Your slides have disappeared. I'm not sure if Joseph.
Yeah. Hello. Yeah, David, I can.
Hello, Joseph.
Hello, I can hear you. Can't you hear me?
Yes, Joseph.
Yeah. Can't you hear me?
I can hear you, but but your slides have disappeared.
Yeah, you should go on now. I'm putting it on.
Okay. I'll keep on. I'll proceed while you are fixing that. So yeah, hand pain for 3 months. We are dealing with something chronic. Now, what exactly is going on the hand? I think the hand because I do not have a good schema, because as I believe you already know, whenever I hear a complaint, whenever someone comes with an issue, the very first thing that you try to do is to recognize a certain pattern, and that's the easiest way to get to a diagnosis, although you still need to take a history and examine. But commonly you hear something and then you compare with what you have in store. So I think hand pain, we might have come across it maybe a number of times, but then it's not exactly the same as something like difficulty in breathing or cough, where you have very well defined the differentials. So for hand pain, uh, I think just some few general questions is I would like to know if it's the entire hand that is painful, just some parts, and then that will help me clarify some things. Am I dealing with joint pain? So I'll just make up something, either to have an anatomical approach, like is it something involving the skin? Is it the subcutaneous tissue? Is it something coming out of bones? Or is it something that the pain is because of the nociceptive receptors are involved? What exactly is causing the hand pain? And then pathophysiologically, is there inflammation going on or not? Because yes, we hear of pain, but not every pain is due to inflammation. So because of lack of a specific schema for this one, I think history will help me clarify some things, and then I can make progress from that. So Joseph, back to you.
Yeah. Can you now see the slides? Yeah?
Yes, I can see the slides.
Okay, so I think we should proceed. I have a very bad internet connection today. Yeah, so the HPI is that she reported a gradual onset of pain in the left hand, which was worsening over time. The pain radiates to the arm and shoulder. It was associated with pricking sensations and numbness. The pain wakes her up at night, but it improves when she vigorously shakes the hand. And she reports that the pain has affected some of her activities like laundry or stealing ugali with the affected hand. But the other hand and the rest of the limbs are pretty normal. But she denies tremor, weakness, swelling of the hand, neck pain, visual disturbance, mouth deviation. There's no history of prior injury. And when I saw her, she was on like 1 month course of pregabalin, which she reported that it didn't help.
Okay, interesting history, and up to this point, I think nothing specific is clicking. So gradual onset of pain involving the left hand, and then it's worsening over time. We are talking of, we're already in the territory of something chronic, a 3-month history. And then what's interesting here is that the pain radiates from distal to proximal, that it's a painful hand, and then radiates to the arm and shoulder, associated with pricking sensations and numbness. So this makes me think of something. We've already, in the next slide, I think we have heard that there is no history of trauma. The pain wakes up at night and improves with vigorously shaking the hand, and it affects some of activities. The other hand, the rest of the limbs are normal. Can I see the next slide? Okay, there is no tremor, there is no weakness, there is no swelling, there is no neck pain, visual disturbance, mouth deviation, no history of injury, and pregabalin doesn't seem to help. So what is going on in this patient? So this pain, as I said earlier, that I do not have a specific schema. So I'm thinking just making up some things that can help me at least figure out what is going on. But So whatever this pain is, there are some sensory symptoms, positive sensory symptoms like, can you project the last slide? So there's numbness. Is that numbness? The previous slide, Joseph?
Yeah.
Okay, so there's pricking sensation and numbness. So these are positive sensory symptoms. Is it okay to say we are dealing with a neuropathy? Okay, some sort of neuropathy, I think it's important to consider some sort of neuropathy, but maybe that by itself, of course, a question comes: what kind of neuropathy are we talking about? And that can be misguided and is purely based on the fact that there's hand pain. This pain is radiating to the arm and shoulder. That's what is interesting here. And it's associated with pricking sensations and numbness. And this pain is nocturnal. So this tells you that whatever this is, it's something serious and problematic to the patient. So the rest of the limbs are normal. So whatever we are dealing with, I'll just give a few examples. So, for example, diabetic neuropathy or diabetes can present with painful neuropathies, but then we expect some sort of symmetry, not exactly, but some sort of symmetry. It's not just one area, most likely because we talk of stocking and glove uh, pattern of neuropathy. We do not see it in this patient, so the other limbs are completely normal. So if we are talking of a neuropathy, then we should talk of something like it's a compressive kind of neuropathy. And another thing that we need to entertain in this patient, although there is no swelling, and I do not remember if you've talked about this, if there is any color change in the joint, but you've already said there is no weakness, there is no swelling. So another thing is, especially for the hand, later on I'll be interested to know the occupation of this patient, but I have not read very much about carpal tunnel syndrome. But then I think that is one of the things I need to entertain in this patient. Compartment syndrome in general, compartment syndrome, we do not have enough data to say this is compartment syndrome. And of course, I think that would be an unusual kind of compartment syndrome. We are talking of chronic symptoms more than 3 months. And therefore, if it was pressure that was building up in that area, maybe some sort of gangrene would have already set in. So I think just throwing or shooting bullets in the dark, I think carpal tunnel syndrome is one of those things. Although, again, carpal tunnel syndrome, I think we would expect some features that let's see in the exam if we can get those, and then some compressive kind of neuropathy. Although, and yes, we are told that this pain is radiating to the arm and the shoulder. So what if the starting point of whatever we are seeing is in the shoulder, and it's involving the hand? But then I think I'm still too confused right now to figure out what is happening. But I'll see other components of the history, like especially the medical history, a history of diabetes. We've talked about the commonest presentation of diabetic neuropathy, stocking and glove, but then a mononeuritis is still a possibility. There is no history of trauma for us to think if it's trauma that is causing this. And of course, another thing is we should not overlook something like bone, although that would be more of wrist pain or pain in the fingers if you are talking of osteoarthritis or something else of that sort. And therefore, I think I'm inclined to think that this is it's some sort of a neuropathy. Although I think other components of the history and the examination will help me clarify the details. So more history, Joseph.
Yeah, that's a very good description of what's happening. So the view of our system was pretty unremarkable. Past medical history, she had hypertension. She was taking Losartan irregularly, and as I told you, she was on pregabalin when I saw her. Family social was non-contributory. Anything?
Okay, so nothing specific, just from the HPA, you talked about some other things like this patient did not have, there were no clues that there are any neurological symptoms, any other neurological symptoms. If we consider this to be neurological, the patient had no limb weakness, had no facial deviation, no visual loss, nothing of that sort. So other components of history, diabetes not present here, although I think, of course, when it comes to investigating the patient, checking the blood glucose is still, I think, prudent. The hypertension and relationship with this one, I do not see any direct link at this point, but I'll see. So let's just proceed with the exam.
Yeah. So let's see the exam. General exam, she was a Latin oriented. She was a febrile. She had no pallor, no jaundice, no low limb edema. Vitals, she had elevated blood pressure, but the rest of the vitals, pulse, respiratory rate, temperature, and SAT were normal. So I did some maneuvers. I hope you can recognize them. When I told this patient to do like what you're seeing in the picture, she said it reproduced the pain. And also, when I tapped on the wrist, also she was saying when I tapped, she said like there was electric shock going to the outer side of the palm. And rest of the neuro and systemic exam were unremarkable.
Okay, this is interesting, and so the interesting thing is, of course, as you projected the maneuvers that you did. I've come across them, but the thing is, you when you, I mean, you do not come across something very often, but then we so I'll tell you, for example, the tapping. I was thinking about it even earlier on, but then the exact significance, I think, because I do not remember all the details very correctly, I think that can cause me to bank on just some specific diagnosis. So, for example, um, I mentioned about carpal tunnel syndrome, and I'm not sure if the tapping, if the tapping is one of those things that produces that. And would I be correct if I talk about entrapment neuropathy? And is it a synonym to carpal tunnel syndrome? So I think up to this point, just one differential that I see, a differential that I have, and of course I have to admit that this is because of lack of a proper schema and my limited knowledge in this. I think the diagnosis that I have is I'm considering carpal tunnel syndrome, and I have this question that entrapment neuropathy, is it a synonym to carpal tunnel syndrome? I'm not sure about that, and so I would need to go and review that. And I think my translation, again, just like I say, due to limited knowledge in this, I think the translation takes me in that direction, that is it entrapment neuropathy / carpal tunnel syndrome that is producing this. I talked about compartment syndrome, and then So compartment syndrome, we haven't heard of the other P's. So pain is just one of the P's. So the other P's are pallor, pulselessness, and any other P's that you can remember. So compartment syndrome, I think based on the time course, I do not see it playing out in this patient, but then I'll be ready to learn about it. And then so other signs that are picked when you tap someone like that. And of course, all for them, what is produced, what is reproduced is not the pain, but it's like spasm. So in patients with hypocalcemia, and those are Trousseau sign and some other signs. So we haven't had anything else that is in keeping with the hypocalcemia in this patient. And of course, hypocalcemia or calcium abnormalities, they present with some neurological symptoms, but they are more of either paresthesias or spasms, which are not the case in this patient. So yeah, I think up to this point, I'm considering carpal tunnel syndrome, and that would be a reason now for me to go and open the books and read about carpal tunnel syndrome in detail and see if it's the case and whether the maneuvers that you performed are truly meant for carpal tunnel syndrome slash entrapment neuropathy, and just to see a close differential, because I do not have other better ones to see if compartment syndrome in general would also present in the same way and in the same time causing this patient. So that's what I have for now.
Okay. And so labs, not interesting. Fuba picture, SR, RBG, RFT, LFT, urine, they were all normal. And this is the end. So you have to tell us the diagnosis and the treatment.
Okay, so for treatment, I would say I'm not exactly sure, because first of all, what is the diagnosis? So yeah, just to make sure that I represent this problem correctly. So this is a 62 years old female who presented with a 3-month history of left hand pain. The left hand pain, which is she's presenting with progressively worsening left hand pain, which radiates to the arm and shoulder. She has no significant history of trauma, known hypertension, not adherent on medications, and the blood pressure is not well controlled. This left hand pain is associated with numbness of the limb, but otherwise no weakness that has been reported. At least on your neuro examination, you said other neuro exam is normal, except that the pain was reproduced by tapping. So what is going on in this patient, and what are the risk factors? Is hypertension associated with this, or is it just the age that is associated with this? And of course, something that you didn't tell me, Joseph, is the occupation of this patient, because I think some occupations, when you are talking of carpal tunnel syndrome, for example, they are more exposed. So, for example, I think even people, so typists, including typists, I think these are very ancient jobs, but we do those things, and we do those things and we place our hands. So when you are sitting at a desk, actually your wrist could be compressed against the edge of the desk or table, for example. And I believe, because I haven't recently read about carpal tunnel syndrome or anything of that sort, so I do not remember the risk factors very clearly, but I think so some jobs are in the lines of what I just mentioned, typists. So even us who use computers, sit at desks and tables, and your wrist is compressed against something, I think those are some of the risk factors, and therefore Uh, I think I do not have, I am not very confident enough to say that the diagnosis I'm mentioning, at least I have a certain level of confidence in it, but I'm considering carpal tunnel syndrome and so slash I said entrapment neuropathy. I'm not sure if they can be synonyms or if they are completely different things. So closely after that, so what I would basically do in this patient, because I've already noted a gap, is I would open different resources like Harrison's Up to Date and try and read about approach to a patient with hand pain and see all the differentials. And then with that, I could come back to the patient and take history now with having proper details about clinical presentation and risk factors, and of course including management, how I could manage this patient. Although I would say part of the management would be uh, or occupational, so occupational therapy basically, and the changes in occupational hazards like I talked about. So those are my thoughts, Joseph. I'll just sit back and learn, because I think I'm completely clueless as to what is going on.
Yeah, not really. I think you're on the right lane. So yes, the diagnosis is Caputano. So this is a simple case, but I'll tell you why I decided to present this case. And so yeah, you're right. It's Caputano syndrome. Entrapment syndrome is a new term. I think I will also take it. I didn't see it, but I think yes, it makes sense because it's what's happening in Caputano. So the teaching point is what is most important in this presentation. So Caputano, how you define it, these are just symptoms and signs which are caused by median nerve compression as it passes through the Caputano. The picture is self-explained there. Uh, it is the most common compressive mononeuropathy that is known. The epidemiology is like that females are more affected than males, a ratio of 3 to 1. Other risk factors include obesity, elderly. So we say, you see, a fat old female who has carpal tunnel syndrome. DM is another risk factor. Pregnancy, I think you might have seen this. Pregnant women will come and say they feel numb in the hands, and then when they deliver, it goes away. As Kalani has told us, there are rheumatoid arthritis, osteoarthritis, they're all risk factors. Hypothyroidism, amyloidosis, other risk factors. The pathophysiology is thought that there is increased pressure in the intracarpal canal, which causes direct nerve injury, impaired axonal transport, and also vasocompression, which cause nerve ischemia. What causes the increased pressure in the intracarpal canal? It was what is not known, but is thought to be vascular in origin. So the presentation is what is interesting because the picture of most people of Capotano is the what was taught, I think, in basic science, that you have to have pain in the median nerve distribution. That is the lateral side, like the thumb first, second, third, and half of fourth finger. But that's not right. The variability of supply of the median nerve is very different in people. So some people can have pain of whole of the end, like what was happening in this patient. So usually you have pain, numbness, tingling. Usually to the median nerve distribution, but as I told you, variability exists. Some people can have just numbness on the wrists, others even though the entire hand, as in this case. So the pain can radiate to the forearm, as in this case, and the shoulder, but it should never go to the neck. If it goes to the neck, consider other diagnosis, especially from compression of the nerve from the cervical spine. Uh, so some people might have weakness, and I've seen this. But should be very severe. Like it's not treated for so long, they can move that part of the hand, and that is bilateral in 65% of patients. So you shouldn't be surprised. The picture there shows the supply of these nerves. Some people, some patient, when you tell them where, they show you exactly one, two, three, half of that. Yes, but others, it can be the whole end. Major teaching points, that one. So diagnosis clinical. You have to hear the history and diagnose the disease. But if you are in doubt, or you want to confirm, you can send this patient for EMG. Should be waste of money, maybe. Bedside tests include what I will show you. Fallen tests, as you're seeing, the top one. The bottom one is the Tinel, and the others that I didn't do with the Darkan, that you have tell the patient to fully flex the wrist, and you apply pressure on the wrist. It's called manual carpal compression. All these should reproduce. They say when I do this, I feel the same thing which I feel when I had these symptoms. So the main thing, I will tell you something. I've been in the clinic several times. We see this patient. I uh, I can say it's the most common neuro complaint I see in the clinic. And whenever I see these patients, they're usually on pregabalin. They're usually on pregabalin. And the diagnosis is usually peripheral neuropathy. So it is never peripheral neuropathy. I've heard David talking that very nice. You said it should be symmetrical. Peripheral neuropathy has three S. It should be symmetrical, it should be slowly progressing, and also it should be sensory. That's peripheral neuropathy. So you think of DM. This patient, they will tell you, started slowly like 2 years ago. It is progressing. It was on the plantar surfaces. Nowadays, I feel like it's on my ankles, and I start to feel my ends also. So slowly progressive and symmetrical. It should, someone telling you they have numbness in both hands, you shouldn't take that, because and peripheral neuropathy start with the longer nerves, so usually start in the limbs, and then the hands can follow. It can start both the limbs and the hands at the same time, but other than that, it can't be peripheral neuropathy. So people telling you they have numbness in both hands, ask them, did it start like on the same time, or it was one hand? And they'll tell you it started this, and then now there is this, but this is more severe than this one. They are having carpal tunnel, and there's I can tell you, not properly treated. Most patients I've seen on this, they're on pregabalin, diagnosis usually miss. That's why we're presenting in here, to try and change this practice of the people that are watching AfroDX on YouTube or on this live session. And treatment also pretty much missed. Give this patient a wrist splint. It's there. Seen, even the NHIF guys can they provide it. It's unfortunate that they will need a diagnosis that not Capotano. But you give these guys an nocturnal wrist splint. You give a splinter, as I'm showing it here. If your hospital doesn't have them, tell them to stock it. It's pretty important. So you tell this patient to wear this splint every night, and to sleep with it. This will make the wrists straight, so that it is not they are not flexing when they are sleeping. So straightening the wrist for 1 or 2 months will reduce the intracarpal pressure for that time, and then it will go away. Alternatively, someone who wants quick results, they can have a steroid injection. I don't know how to do this, but I think maybe some OT guys, they can do this, or someone who has learned. So you inject a steroid, usually methylprednisolone, a dose of 20 to 40 milligrams. Start, and it goes away. Alternatively, you can give oral steroids plus splinting, and the steroid here is just 20 milligram of prednisone for 10 to 14 days. So there is no benefit with NSAID, gabapentin, or pregabalin. All of these patients I've seen, they'll report partial or no response to the gabapentinoids. They're usually giving gabapentinoids. And so if they are not responding, or if it's very severe, they're having weakness, probably, you send them for surgery. And the surgery is just easy. The surgeon will open here, there is a fascia, and then they'll cut it open. They'll relieve the pressure. I don't know who will be the neurosurgeon or OT, I don't know. But you send them to surgeon. Yeah. So the main purpose of this presentation is the uh, if you're seeing this patient with hand pain, don't say it's peripheral neuropathy and dash pregabalin. Consider Capotano. Most common, a lot of it, it is there outside. And do the right management. Give these patients a sprint. It will help them. Yeah, that was it, David. So simple, but thought we should present this for the benefit of everyone.
Oh, thank you, Joseph. Well, so I think for me, uh, simple for you. Maybe you've made a number of diagnoses. I've heard or read about carpal tunnel syndrome in the past. Maybe not seriously as an individual entity. And as you are saying, maybe I think my knowledge of carpal tunnel syndrome was mostly based on the basic sciences. And so, as everyone here can see, although I finally made a diagnosis, but then I struggled because, and I think this is a typical representation of what we go through in diagnostic processes. That so what we start with is pattern recognition and see, okay, I'm seeing something. Have I ever seen this thing before? And if yes, what is it? I'm trying to see if there is a specific pattern. So you see something completely new, or could be because the presentation is pain, but then the pattern of pain is not very familiar. So I think this is just reminding me something that we cannot exhaust medicine. We cannot exhaust medicine, and that's the reason why we need to keep learning every single day. And thank you for presenting it and for the teaching points, because even the things I talked about. So I mean, in my reading, I'll have to see now the occupational issues that I talked about. I'm not sure if you came across them, and if those are related to the same issue, or is it a completely different issues. So it's been a lot of learning for me, and therefore I have work to go and do. Thank you very much.
Yeah. So yeah, I forgot that point. You are right. So the literature says it is also thought that some occupations, the occupation that use hands a lot, is a risk factor, but they say it is hard to come out with that because the occupation will be for a long time. Like someone is working as a mechanic for 30 years. So by the time they're having Capotano, they are 50 or 60. So is it the age or the occupation that is hard to decipher?
Okay, interesting. Uh, we still have some time. Is there anyone with any comment, anything to, or to share the experience before we close? I see there is a hand from Macklin. Please welcome.
Okay, thank you very much for this. I really learned a lot. I just wanted to ask one clarification. You had mentioned a number of risk factors that might eventually lead to carpal tunnel syndrome, including hypothyroidism, amyloidosis, rheumatoid arthritis. So, in the clinical practice, when you find a patient with carpal tunnel syndrome, how often, or is it mandatory that you have to look for these risk factors and investigate each one of them, or how do you go about it in your clinical practice? Thank you.
Yeah, thank you very much, Macrean. So that's a very good question. So as you're saying, risk factors are things that will increase your chances of getting a disease, but they're not the cause. So they can be there or they can not be there. It doesn't rule out the disease. In my practice, to be honest, what I have seen most commonly is 1, pregnancy, 2, obesity, and 3, elderly. This I've seen. Pregnancy, a lot of it. They are even pregnant. The OBGY tells them go to physician. They come to me and say, oh, Capotano, if it's severe, you can wear this, and it goes away when you deliver your child. Elderly, I cannot tell you how many times I find them. They come for a fill. They've been written something like G63, the code for peripheral neuropathy, and you say, "Is it helping?" They say, "No." Where is the numbness? They say it's my hands. Okay, it's not peripheral neuropathy. You should not do that. You should do this. And the also obese people. Yes, I've seen young obese, especially the females, young obese with this presentation. That the rest. So I have not seen DM, but I can imagine if someone is DM and present like this, it will be straightforward. Someone will say it's peripheral neuropathy. But thank you very much, Maclean.
Do we have any other question or comment? I do not see any other hands. So yeah, today's case short, but very informative, at least for me. I'm not sure about everyone else, but I learned quite a ton. So if there is nothing else, we congratulate those who had exams and they are done with exams. I know there are some who still have some, but congratulations to the ones who are done, and all the best to the ones who are having exams this week. So again, as always, we are looking forward to people coming with cases. We hope in the next few weeks or months, maybe people will come with cases to share, so we can learn from everyone. And I think when the crowd that comes with cases or discusses cases becomes bigger, I think the learning will be much more compared to when it's just a handful of people who are doing it. So if you have any cases, please bring them. We still have a couple in store. I have Roland's case, which I think we'll hear about very soon. And so if there's anyone else who has a case, please just bring the case. You can communicate with me or Joseph and share the case, so we can learn from you. And for those who are willing to discuss, last week we had Fabian discuss a case here, and he did a very impressive job. So I hope that encourages other people to show up for discussing. So if there is nothing else, I wish you a good night and see you next weekend.
Good night. Good night.